So, welcome to all of you who've joined us this morning. This is the final wrap-up webinar of a series of 5 that we broadcast over the last couple of months, which was sharing the work that we've conducted for the European Union's health programme over the last couple of years. My name is Niamh Lennox-Chugani. I am the healthcare lead at Optimity Advisors in Europe, and I'm absolutely delighted to be joined by our panelists today. So we have here to talk to us today, we have Professor Áine O'Carroll, or Áine Carroll. I don't know why I insist on putting that O every time, Áine. It's an impulse, I think. So Áine Carroll is Professor of Healthcare Integration and Improvement at University College Dublin. She's also a consultant in rehabilitation medicine at the National Rehabilitation Hospital in Dublin. She's co-director of the International Foundation for Integrated Care Ireland, and she's a senior associate of the International Foundation for Integrated Care. So I think we can safely say that Áine is an expert in the field of integrated care. In terms of experts, she's also joined today by Dr. Albert Alonso, who is chair of the International Foundation for Integrated Care. He's a senior researcher at the Hospital Clinic in Barcelona, and he's also, if I remember correctly, Albert, he was the chief investigator for Project Integrate, which is one of the largest projects, evaluation projects and research projects into integration across Europe. That has been funded by the European Union. Am I correct, Albert?
Not totally. I was the responsible person for my hospital as one of the partners in the consortium. The main responsible was Magda Rosenmüller from AES Business School in Barcelona.
Right, okay. And then finally on our panel, we have Philippe Domanski, who is from DG Santé. And Philippe was the lead for the work that Optimity Advisors was commissioned to conduct looking at integrated care across Europe. Hopefully you will see that we've got a very venerable panel of experts to talk to us today. Now, the reason that we thought we would have this wrap-up webinar was there were a number of questions that came up time and time again from the participants in our previous webinars. And we've consolidated those into 3 primary questions, which we are going to pose to our panel today. We'd also encourage you to contribute to the discussion. You should see a Q&A button in the panel at the bottom of your screen. So if you have any comments or questions as we go through this discussion, please do share them on that Q&A panel, and we will try and consolidate those at the end of our discussion today. So we're going to wrap up at 12:45. And I'm going to start off with our first question, which I'm going to pose first to Philippe. So one of the questions that we had, Philippe, that came up several times was, is there a need for integrated care to operate at an international level across the European Union, not just at country level? And what do you think the advantages and limitations of that approach might be?
Thank you, Niamh. Good afternoon from Brussels, where it's already 1 p.m., 5+1. So the shortest answer would be probably yes. But to make it longer, I think this is the way the health systems already developed in the EU. Let's think about cross-border healthcare directive. Even though the number of patients who cross borders to receive planned care is not high, but still this is the direction health systems go. We have also examples of health systems, national health systems or regional health systems that already cooperate. the example which will be probably even better than for me known for Albert is Cerdanya Hospital or Cerdany Hospital near the Spanish, to be exact, Catalonian and French border. So there is a hospital, cross-border hospital, and as I suppose, it doesn't focus only on providing purely hospital services. Probably there is also kind of follow-up, which could be labeled at least as coordination, if not the integration of care, but still. So this is one example. In general, we as the citizens of the EU, we travel a lot. We switch places of where we live. Luxembourg is an example of the country where many people work, although they live in neighboring countries like Belgium, Germany, or France. So I think to follow the way we live, health systems should probably also become more cross-border. I could say that, for example, the twinning that was organized within the framework of the European Innovation Partnership on Active and Healthy Aging, the twinning between Scotland and the Basque Country was probably kind of step towards that direction. Of course, it didn't, its result wasn't immediate integration of care between those countries, but it's an example of cooperation. So probably also in everyday practice, in provision of services, we should expect at some scale, not massive scale, but at least in cross-border regions, we should expect coordination also across the borders. Very quickly, limitation, because I think I mentioned already the advantages, which is to follow the way people work, to be for the health and social care systems to be more flexible, to be more adapted to the way their clients behave, their clients live. I think that financing could be an issue, since it would involve at least two national or regional systems, two different systems to finance services. We all know that there are issues sometimes between health and social care system within one country when it comes to financing integrated care. So adding international layer would probably even more problematic. The other thing is communication, which is crucial for integrated care. If the cooperating countries or regions from different countries, if in those places people don't speak the same language, I mean, in purely linguistic terms, it could be a problem. And add to it additional layer, which is taxonomy. Each healthcare system has its own ways of naming things. So in order to integrate care from two different systems, this issue should be solved. So as I started, I think this is probably at not very large scale, but it's a future, one of the scenarios we should take into consideration. Thanks.
Thank you, Philippe. And on that taxonomy issue, I think that was one of the key findings of this and other studies, is even the definition of integrated care is not necessarily itself agreed across different countries in Europe. Albert, what have you got to add in answer to that question?
Yes, thanks, Ian. I would say that I would agree basically with Philippe. Perhaps the only thing that I would like to put in, to reinforce the value that, in my view, it has already got, is the fact that Europe provides an incredible source of different, varieties of cultures, people, understandings about health and well-being. And I think that when it comes to integrated care in particular, I mean, perhaps we need to acknowledge that we do not have all the answers. And therefore, by having the opportunity of exposing ourselves to the rich variety that Europe has to offer in terms of these new understandings, I think that in many ways we increase our capacity to make integrated care happen at the local level. And I think that Philippe was actually pointing at a very good example of that, and that is the twinning exercises. My feeling is that, beyond the successful experience between the Basque Country and Scotland, I think that we perhaps could actually find other, significant encounters of, different regions, because most of the time it happens, among regions, where, by having this proximity about, a region that is a little bit more developed than other regions, there was this sort of cross-fertilization that actually ended up with having something that was, of much greater value, for the original, for the adopted region, the one adopting integrated care. So, as I said at the beginning, I totally agree with Philippe. I think that Europe means, this issue about being part, all of us, of a common space, but also, the variety provides, a richness of arguments that allows us to do better, even in our local environments. That would be my comment to that.
Thank you, Albert. And Anya?
I agree with everything that Philippe and Albert have said, but in order for me to answer the question, I can feel a little bit conflicted about it because it depends on which hat I'm wearing. So as a clinician, as a former designer and implementer of integrated care solutions, but also as a receiver, and now also in my role as IFIC, I think I might answer that question slightly differently depending on which perspective. So I think it suggests that almost the country thing is kind of done. And it isn't at all. There are in every country pockets of excellence. So I think we've still an awful lot of work to do within our respective countries. But that said, I think there's an awful lot more that we can do together. And it's certainly better together. We can learn from each other. We can test ideas and solutions and methodologies together. We can come up with a shared taxonomy, which is extremely important, because when you look at systematic review after systematic review, they always conclude with methodologies need to be better and we need to do more research. So let's get more agreement about the words that we use and the methodologies that we're going to employ. And I know we're going to talk about evaluation in another question, but agreement about the right mechanisms and processes for doing, whether it is setting up programs, whether it's evaluating programs, whether it's looking at the impact of programs, is extremely important. And I completely agree with Albert that we are stronger together than we are in isolation. And that's that's the mission of the International Foundation for Integrated Care, is to bring together like-minded people and to create a community of practice and a social movement around integrated care.
Thank you, Anya. So I think there are aspects, particularly around shared learning and shared experience, that certainly there's a lot of opportunities for cross-border collaboration, and there's a policy move towards cross-border healthcare potentially, and we need to have that in mind, but there's still a long way to go in country in terms of integrated care as well. Okay, thank you. So I'm going to move on to our second question, which was one of the tools that we talked about and that was included in our evaluation in our study, and which has been the subject of other funded programs through the EU health program, is the Sirocco tool, which is a maturity assessment tool for integrated care. And this was a question that I'm going to put to Albert first, which is a little unfair because this was a question that in fact came from Albert himself. But I think it's a good opportunity for him to get a chance to discuss it with Philippe and with Anya. So your question, Albert, was tools like Sirocco are good for monitoring how change is happening, but understanding of how to manage change is crucial. So you asked for advice on structured change management approaches. So perhaps you can tell us a little bit more about your thinking behind that question.
Yes, thanks. Oh, can you hear me well? Yes.
Yes, we can hear you.
Yeah. Well, I think that first of all, I need to start with a disclaimer. So change management is not actually my field, and not certainly a domain where I can claim much knowledge about, right? So in attempting to answer the question, I will just draw on my experience in trying to introduce integrated care from or in a tertiary university hospital in Barcelona that also acts as a community hospital for a urban area of around 540,000 inhabitants. This is a journey that we started 20 years ago and still goes on. But I think that I have, along these years, I have managed to get, some better understanding, perhaps. So I will try to base my answer on that. So when it comes to successful deployment, my rule of thumb basically is Laut's maxim that all integrated care is local, as we were saying just a while ago. And in my opinion, forgetting this rule many times, leads to significant failures when we are trying to move what was a successful, development, perhaps on a pilot stage, to another setting, a different one. And I think that we need to realize that when we are introducing a new intervention in a given setting, that means, in fact, that what we are doing is making available a new set of resources or capacities to the involved people that will actually be, introducing or doing that intervention. So people will be using these resources, but not necessarily in the way that we were foreseeing. So the point would be that when we are looking into the results, perhaps the results are less related to the original qualities of the intervention and more related to the way that people decide to adopt these resources and therefore, carry on with intervention. So if we accept that this is the real situation, then we can already anticipate that there's a need to do something about it. And we need certainly to pay attention to the intervention and how it changes the way that people do things. And I would argue that it means basically two things. Firstly, we need to consider a change management strategy so that in a way we can handle the situation and maximize the expected benefits of the intervention. But secondly, we need to be able to monitor how this change is happening. And this is what tools like Sirocco allowed us to do. And perhaps I would say that, monitoring means going a little bit beyond of only paying attention to the outcomes and also paying attention perhaps to other things such as how people are reacting to it, right? So as I said before, you're not an expert in this domain. However, when I deployed what in principle were tested pilots, and we were trying to scale them up, we found that having some overall guidance was important. So in our case, it was useful to use things like Kotter 8 steps model as a source of inspiration. And by source of inspiration, I mean that it was not a systematic application of the model, but more a tool that allowed us to think about the relevance of different elements. So just allow me to give you some examples. Perhaps we needed to think about the importance of the change and whether it was equally perceived by everybody with the same level of urgency, or how we could rely on the regular actors in the field to lead the introduction of the intervention and not being asked as the researchers, the ones that could actually do that, right? So although Kotter was useful at the working level, many times we use more, so to say, operational tools. For instance, the PDSA, a continuous improvement cycles, that is already something well established in the healthcare domain. So only in a few cases, we actually experimented with others like, the normalization process theory. Basically, most of the time, we use Kotter and PDSA in combination to do that. And as I said, many times it's an inspiration, as a way of trying to think better about the things that we were doing. So at this point, basically, I would like to share a reflection with you that I think that requires consideration. And I have to acknowledge with some embarrassment that I only became aware of it recently after reading the Spread Challenge report that was published by the Health Foundation last September. So the main conclusion of this report is that we, those of us that are actually playing a role as innovators in new models of healthcare delivery, should pay a little bit more attention to those adopting, our innovations, those that will be actually replicating the things that we are doing in their own settings. And in this report, this greater attention implies two things. Firstly, that we need to codify our interventions for adoption. This means that we need to provide some indications about things like the skills or capacities that the intervention requires, how the intervention may have an impact in the cultural context, what are the implications in terms of team building, and so on. So these are important things that we need to codify in our interventions. But secondly, it's not only about the intervention, the product itself. It's also about how we can effectively support the take-up. So in this sense, perhaps we need to think about programs, perhaps a little bit more sophisticated, designed for adoption. So we do not only need to ensure buy-in, but also that we have ways of supporting and that resources will be available to adopters to ensure that implementation will be happening. Yeah. So in summary, I guess this is rather a new way of thinking about replication and adoption of integrated care practices. It means that the work that many of us have been doing around the design of new practices might have been a little bit suboptimal because we did not pay sufficient, attention to the challenges on the adopter side, right? And this was important. Yeah. So this, in my view, are important things that we need to think about if we want change to happen. That's it.
Thank you, Albert. And I'm a big fan of Kotter myself, but for me, the big gap in Kotter is exactly around that understanding of how people take on change and the effect that change is going to have on their working lives. And I think in integrated care, we've often been, I think, particularly when you're passionate advocates, as we all are, you don't quite understand or gauge sufficiently the level of change that you're asking people to take on in the way that they work and the way that they think and do things in very different ways. Anya, have you got any thoughts to add to that question?
I have, and one of the attendees, Donna, has just made the point in the chat room that I'm about to make. I raised this. I was thinking about this quite recently. I was working on a paper, on a piece of work that we had done before, and I thought to myself, change management. Isn't that an oxymoron? So I posted it on Twitter just to see what people thought, and it was really interesting that the people that responded were quite divided in their views. So some thought that change management was the greatest thing since sliced bread, and others thought that you cannot manage something that is organic, and to try and manage it is to stifle creativity and innovation. So it was really interesting. And I did a little bit of kind of looking at the backgrounds of some of the respondents. And those that love change management seem to be involved in programs of change, and those that didn't were more clinicians, or the creative side of change and innovation. So I thought that was really interesting. And all I can say really is from our experience within the health service executive, within the clinical programs and the integrated care programs, within clinical strategy and programs, we learned a lot as we went along. So speaking as a clinician initially, the idea of change management was, number one, something that I didn't understand because I'd never come across it in the course of my training as a clinician. And the second thing, I saw it as a barrier I just wanted to get on and do. So I think as practitioners, frontline practitioners and clinicians, we just want to get on and do. But there was a very famous footballer in Ireland who said, fail to plan, plan to fail. And I realized after a few years that actually thinking about these things is really important to successfully implement the change that you want to see. So using some form of change management, or however that needs to be phrased within your own local or national context, is really important. And I think there's lots of ways to do that. What I think is key is to realize that you do need to take a change management approach, but there needs to be agreement about how you might go about that. And I think, once again, that we can share ideas around what has worked in different contexts, what has worked in different areas that other people might wish to share, and so that we're not repeating the same mistakes that have been made in other countries and in other areas. And I think that the more that we can share about our experiences and our learnings, and in many ways, not just the successes, but also the failures, I think there's a huge amount that can be learned from the things that didn't go quite so well. And I feel myself being drawn back into the agreement about taxonomy. So the words do have an impact on how people feel. So I think that management for clinicians just raises hackles, and yet you won't get the work done if you don't use the skills of our management colleagues. So I think the more opportunities that there are to bring those different individuals together and share the knowledge that has been generated both locally, regionally, nationally and internationally, and get agreement about the approaches that you want to take, I think that will really propel us into a completely different way of working. And of course, I should say, I've mentioned clinicians and managers. Having those conversations with patients, with service users and with carers and families is extremely important. So nothing about us without us.
Yeah, and I think that point is being reinforced by Donna in her comments there, and around how you engage with people, including patients, through collaborative co-design and implementation, which I think, certainly our findings in the European study were almost all places are still quite far behind in terms of really meaningfully engaging with populations and with people around the design and delivery of integrated care. We still have quite a way to go there yet. Philippe, some thoughts from you.
Thank you, Niamh. So our role, as the commission, is slightly different. You had two representatives of practitioners, those who are really engaged in managing change, or not managing the change, but doing changes in the systems, the healthcare systems. Our role here is different. We are rather as a hub. Sometimes I say that all over the EU, the closest way is always via Brussels, which means that we don't have experience in changing the systems. What we try to offer is to give an opportunity to the integrated care community to reflect also on change management. So we finance different projects, different joint actions, etc., that are about integration of care. So, for example, quite recently, ActAtScale project finished, and one of the issues there was change management. There were other projects like Project Integrate or CRODIS. All of them, at least to some extent, touched upon change in the systems. To what extent we can manage that change? Of course, it's a question. I think it's like with the climate change. To what extent we can stop or reverse or change the climate change, and to what extent we should be prepared for it happening. So, as I understand from the discussion we have now, the systems will somehow evolve, because not only the way we live changes, but also because of the fact that demography, the disease burden, all that stuff we know very well is different than it was previously. So probably the question could be how to make us prepared for those changes, even though if we cannot manage them. So before the webinar, I was quite sure that we can talk about change management, but now, especially when I heard from Amy and also when I saw Donna's comments, which is good. I mean, we should use opportunities to learn and to question our opinions. So here I will be quite unconclusive in my reply. Right.
Well, that's what this discussion's all about, Philippe. Thank you. Just to remind people before we move on to our third question, if you have any questions or any comments, please use the Q&A tool at the bottom of your panel. We have one question already from Tony, which we will come to after our question 3, which I'm going to ask Anya to answer in the first instance. So, integrated care is expanding. It's expanding beyond healthcare. It's expanding into social care, into public health, local communities. So how do you see approaches to evaluation and evaluating the impact of integrated care changing to meet the different needs of policymakers and integrated care providers?
Thanks, Niamh. When we started to think about all these issues in Ireland, we're thinking about definitions, terms, taxonomy. What we realised early on was that actually it wasn't really up to us to come up with a definition of what we thought integrated care was. So we did a piece of work with the organisation, an umbrella organisation in Ireland called IPOSI, where we asked Irish patients and carers to give us their own definition of integrated care, which should be coming up in a slide now, if it's there. Yeah. So the definition, there was a series of I statements, and you can, if anyone's interested, you can, this is on the IPOSI website. So Irish patients' definition of integrated care is that it's care that provides me with access to and continuity in the services I need when and where I need them. It is underpinned by a comprehensive assessment of my life and my world, together with the information and support I need. It demonstrates respect for my preferences, building care around me and those involved in my care. So I think that that definition speaks very well to the question, because the Irish patients do not see services as being excluded from what's in their community and what's in their world. So I think that was a really, really powerful definition that really puts it up to the likes of us that are involved in integrated care across different sectors. So when it comes to evaluation, any evaluation must take the different elements of that definition into account. But that's where I think we are challenged, because in terms of evaluation, I think approaches generally need to change, because there's so many different types of evaluation. There's formative, summative, developmental, lots of different ways that you can carry out evaluations. From the different evaluations that I have seen, a number of them are quite positivist in different jurisdictions, and are really, you almost feel when you read the reports that they're designed to support the current status quo, as opposed to really providing a really good, scientifically robust critique of the work that has happened. I think that's really important. So there's huge variation, and I think that there is, we really require a good, strong evidence base for the tools that we use and the approaches that we use in integrated care, whether that is locally, regionally, nationally, or internationally. And that's where I think collaborations can really come to play, so we can work through these questions together. But personally, I like to use in my clinical work, but also in my work on integrated care, I like the Don Abedian model. I like to think about things in terms of structure, process, and outcome. And especially when you are in the process of developing integrated care and integrated care pathways, it's a very useful approach, because at the end of the day, your funders want to see what is happening. They want to get a sense that things are happening. So even if you don't have results from a patient level outcome, you can report on the changes in structure and process that can happen as you are developing your integrated care pathway. So, and there is a real globally an interest in impact. So what is the impact of your intervention or your program? And again, like everything we've discussed today, it depends what you mean by impact. So do we have clarity? Do we know exactly what we mean by impact? And I think it's interesting when you just take a dictionary look at the word impact. It's the action of one object coming forcibly into contact with another. Or it is a marked effect or influence. And I think that actually you could use either of those definitions when we're thinking about integrated care. Because I often think that we spend a lot of time in doing the do and not necessarily thinking about unintended consequences. So for other populations or other people, it may indeed feel as if they have been hit by something with a great force. So I quite like that when I was thinking about impact. But there's no doubt that impact is a multidimensional concept. And there are some definitions that focus on a very precise understanding, whereas some have cast a much broader net. So like we discussed earlier, having agreement about what we mean and how we might go about measuring that, I think, is extremely important. And these things need to be thought about early. So if you were to think about taking an action research approach to it, this would be part of your pre-planning stage, that you actually do need to be thinking about how might you evaluate and measure the impact of the intervention that is being suggested. So, and I think that going back to what we were talking about in question 2, I do think that the end user has got to be involved in those discussions. In Ireland, our Irish patients have made it very clear about what their expectations are. So any measures of when we come to evaluation, we'll have to take the definitions and the I statements into account. So in conclusion, I think that there need to be explicit conversations with different stakeholders about how to go about evaluating and the definitions that are used, so that we can come to a shared understanding of what it is that we're trying to do and what it is that we're trying to achieve through our integrated care interventions.
Okay, thank you, Anya. I'm conscious of the time, so I'm going to ask Albert and Philippe to be brief in their responses, if you can, please. Philippe, I'll come to you first. Sorry, Philippe, we can't hear you.
How about now?
There.
Sorry. Okay, so I said that I have the impression that the concept of integrated care has evolved. It became broader. At the beginning, it was rather integration of different types of healthcare. Then we added social care, long-term care, which is somewhere in between. But some people say we should also, when we talk about integration of care, we should also think about issues like housing, even urban planning. So if we agree that this is integrated care, this broader, in broader sense, we probably should think about possibly adding the aims, the goals of those different sectors to the framework we use for assessing integrated care. Let's think about housing, that if there is a patient who needs some improvements in his or her home because of condition, maybe also we should think about asking the question, what is housing for, apart from giving people shelter, roof over their heads? And if it is about something more, how this aim, this goal could be taken into consideration when we talk about assessing integrated care. So I will finish here, giving also Albert time to react.
Albert.
No, but very briefly, I think that Anya has basically touched on all the important points. So perhaps the only thing that I would add is that sometimes, in addition to the patients and the care perspective, we also need to expand that to the community or the area where you are actually trying to intervene from an integrated care perspective. In order to make sure that also all these other, social components of health are being taken into account. That's it.
Thank you, everybody. And we have a few questions or comments, and I think there have been some comments from Donna around reinforcing Anya's point around evaluating the impact of and on citizens when we're looking at integrated care and the impact of integrated care. We have a question from Tony, which is a question around transformational change or radical change in order to move forward with integrated care. What's the panelists' view? And he goes on to expand on that by saying, my rationale on the previous comment is that in the former Soviet countries, they radically changed their health systems that facilitated some levels of integration. I would just say in response to that first, if I might, as moderator, is I worked in the early years in the post-Soviet republics on integrated care, particularly in infectious diseases, where their focus was on integrating infectious disease programs. So rather than having siloed programs, they were at least putting some of those siloed programs together. And it was only at that stage that they were starting to think about actually how the whole health system fit together. And it was having those discussions that prompted them to think about actually we need to redesign the entire health system. And obviously that was a context in which radical change was essential. It had to happen because the entire system had been broken. But I'd be interested in others' thoughts and experiences of radical change. So where there's been huge social and political upheaval, and what consequences that might have for integrated care. Philippe, any thoughts on that?
I just wanted to say that answering Tony's question, we should first ask the question, what's the situation in a given system? What came to my mind is the Basque system that was changed towards integration of care, and the trigger for it was the financial crisis. So it was a situation of immediate need for change. So probably it was more radical than transformational change. Of course, if in a given system we have discomfort that the crisis isn't just around the corner, that we expect that things will change in longer term, then I would go for transformational change, especially that changing things is very difficult. We as people rather don't like changes, especially if they are in our area, whatever it is, in private or professional life. So having more time having longer time perspective gives us more time to prepare everyone impacted by the change to make it happen. But I recently saw some comment on the Twitter that this is the difference between experts and non-experts. The non-experts have immediate answers, and the expert starts with saying it depends. So, yes. In my opinion, it depends on the context, on the situation, which triggers the need for change.
Yeah. And I think, to paraphrase, I think it was Barack Obama, every crisis presents an opportunity. And that's certainly true in integrated care. I know that we're going to run slightly over time, and I'm going to take the moderator's prerogative and do that, because I think this is a really interesting discussion. Because I think the follow-on question which we have is around the panelists' views and any practical recommendations around sustainability, which I think leads nicely on from this idea of you know, having potentially political and social situations which can prompt integrated care. We're all conscious that integrated care is often held up these days as the answer to the sustainability challenge within various healthcare systems, and as evaluators we are also equally conscious that it is not the answer to cost savings, because you need to invest quite a lot to make integrated care work. But I'm going to come to Albert and Anya on this. Albert, would you like to have a response to that first around sustainability?
Yeah, so I think that political will, it's really important, but even beyond that, I think that you need to actually get this alignment, you know, across the different levels that you need to take into consideration. So from the political level or the decision making at the top level, you also need to convince or to have the alignment of the different institutions and providers, also the one of the professionals, and perhaps also that of the communities, you know, patients, carers, and third sector. When you actually get there, when you are actually, you know, convincing them all that we are on the same boat, then perhaps, you know, sustainability has much greater chances, regardless of the changing environment, you know, and political climate.
Great, thank you. Anya?
Yeah, I agree with what has been said. I think and I can only really speak from my own experience. The sense that I have at the moment is that everything has got a shelf life. And in this global world in which we live, that shelf life is growing shorter and shorter all the time. So integrated care, whatever that means to you as an individual or as a country, seems to be being phased out as a new thing. And this whole area of population health approach seems to be the buzz term. And we've seen this, especially in the NHS, about how nearly every 3 to 5 years that things are being redressed up in a new shiny wrapping and a bow put on top. But actually we know, those of us that have been following these developments, know that they're just building on the work that has gone before. And I think that that's probably the right way to do it. So small incremental change, because as far as I can see, and I've been looking at these programs for a very long time, big bangs don't necessarily work. So there are lots of examples where there has been radical or transformative change, and I'd be really interested in discussing. We don't have time, but it would be an interesting discussion about what is the difference and looking at the theories behind that. As somebody said to me, you know, in many ways, what's in a name? You know, it just means a big change. So Canterbury would be another example. But yet, so it looks really good as a short 2-page summary, but actually when you explore what was happening underneath, there was lots of things that were happening already, but it was another lever for change. So I think identifying those of us that are involved in these types of change efforts, what are your levers? You need to be thinking about that. So for example, in Ireland, we are constantly restructuring. And we're about to go through another restructuring. So that may be seen as a barrier, but actually it may present an opportunity. So for those of us that are involved in the design, the implementation, or the evaluation of these programs, I think we need to be much more agile in how we respond to these levers and these opportunities, rather than seeing them as barriers, because these things are part of our landscape as much as anything else, as much as models of care. But these changes, these politics in particular, is part of our landscape, and if we don't adapt and become much more agile about how we respond to these things, we just won't be relevant anymore. So I think that, and we can achieve more, as I said earlier, we can definitely achieve more together. And that's, you know, coming together as a community of practice, I think is just really supportive, and I think we'll do more faster if we do that.
Thank you, Anya. And I think we've come to the end of it. I don't think we can go over very much more, because I'm conscious that people have probably joined in their lunch hour and they're probably running out of that time. So what I would like to do is I would like to thank very much all of our panelists, Albert, Anya and Philippe, for taking the time out to join us today. I think we could have gone on quite easily for at least another 20 minutes. Having this discussion, but I hope it was of interest. I've certainly seen we've got some very positive feedback from our attendees, so hopefully it has been of interest to our attendees, and I'd like to thank our attendees as well for logging in and joining us today. We are going to make the recording of this webinar available online. What we're also going to do is the panelists have agreed very kindly to share some key resources that they use in designing and implementing integrated care, which we will send out by email to everybody who was attending the webinar today. So I would like to finally again thank all of the panelists and all of the attendees. And I look forward to corresponding to any of you by email. If you want to get in touch with us, please do. And have a great rest of your day. Thank you very much.